he did a rotation with Dr. Salvania, and he's been coming back since that first time, 6 or 7 years ago. It is my honor and my pleasure to welcome to the stage Dr. Gordon Liu.
I'm getting my bearings straight. Now, I'm going to start my time now, okay? So as I'm speaking here, start, okay? So good afternoon, everyone. Wow, it's a big crowd today. Again, for those of you who came by to the earlier talk, I want to apologize. I am feeling a little under the weather. I promise you it's not TB, okay? I had my quantiferon checked recently, so I'll hopefully be holding up okay. I'm sorry you're stuck with me for the next half an hour. But when I was invited to do this talk, it was very humbling because, again, as Carl said, I've been coming here for a couple years, and this is a topic that's very passionate to myself. So I know my colleague had mentioned the objectives, and I just want to go over it briefly, that this will be a brief overview of chronic immune activation of patients living with HIV. We are going to be talking about a little bit the consequences of chronic immune activation and its implications for patients living with HIV, and really looking at the holistic primary care aspect of patients living with HIV to ensure that the chronic immune activation is identified early and mitigated appropriately. So, the first slide, this is the changing epidemiology. So HIV-infected adults have a higher risk of myocardial infarction, end-stage renal disease, and non-AIDS defining cancers, but they occur at similar ages than those without HIV. So if you take a look at some of these figures. So the first one, this looks at myocardial infarction. The little white dots are individuals who are HIV negative, and the black dots are individuals who are HIV positive. And you see that there is a statistically significant difference in the number of cases of myocardial infarction with patients living with HIV. And this could be a higher incidence of greater progression of high-risk plaques that develop in patients who are HIV positive versus those who are HIV negative. The same theory also applies to patients with end-stage renal disease. You see that there is a significant gap, and also non-AIDS defining malignancies. So that's really important for us to point out. And as I'm going through this and make sure everything's good, sorry. There we go. So this is believed to be secondary to high levels of inflammation and immune activation observed in patients living with HIV, despite, so I think that's a key word there, despite being virally suppressed. What the viral load is when somebody is first diagnosed with HIV, and then at ART initiation, the viral load will slowly come down and become undetectable. The line below that is the line of inflammation. That is patients living with HIV, that is the line of inflammation, and then below that is patients who are HIV negative. So why is there a gap? Why is there a gap between negative patients versus positive patients? So there are a couple of studies that took a look at this and looked at individual markers on why this is occurring. So the first one on the top right, that study looked at soluble CD14, and it found that it was independently associated with coronary calcification. So we know patients living with HIV, even with a suppressed viral load, have a higher level of CD14. The second study, this was looking at elevated biomarkers. So this was looking at IL-6, looking at CD14, and all of this was also higher in patients that were HIV positive with a suppressed viral load. The next one is a group by UCSF. Priscilla Su is a cardiologist out at UCSF that looked at levels of IL-6, which were elevated in patients living with HIV, and that increases, that sole marker, there's an increased risk for atherosclerosis. And then the next one is a little bit closer to home for me. Dr. Bernard Makatangai, who is the big researcher at the University of Pittsburgh, him and a group looked at inflammatory biomarkers. So that was IL-2 alpha, IL-6, CD14 markers that were actually elevated and showed mortality risk among HIV-suppressed men. And the last one was a study that showed plasma-soluble CD163, and these levels were elevated and were independently predicting all-cause mortality in patients living with HIV. So inflammation in chronic HIV, when an individual is virally suppressed, why is there continued inflammation? Why is there this chronic, in the long term, all this inflammation that's occurring? So there's a lot of hypotheses that we've seen, but there's not one that we can say this is exactly the reason why that there's chronic inflammation. So the first one we can take a look is viral replication and persistent viremia. Is it true, that there is increasing viral replication in tissues even if someone is virally suppressed, and that there is still low-level viremia? So we actually know that's true. So if you guys check a viral load on one of your patients and it ends up being undetectable, but how many times have you seen maybe in 3 or 4 months sometimes they spew a little bit of viral load, like maybe 61 or 150? That's a viral blip. So that can kind of help us justify that persistent viremia type of theory. The next one is microbial translocation and dysbiosis. This specifically looks, over the last couple years, we've been doing a lot of research on the gut genome. So looking at the gut genome, we know that everybody's gut genome is different. And a lot of studies are looking at the gut genome of someone who is HIV positive versus someone who is HIV negative. So in an individual living with HIV, we know that there is bacteria that promotes inflammation in the gut, and it overwhelms the bacteria that actually helps with chronic health. So what happens when somebody is newly diagnosed? We have this inflammation, and it affects the gut, there's some dysfunction, and then when they start treatment, there's actually not a complete recovery. And then you get what we call a leaky gut, which is when you have chronic inflammation that's spilling in the gut. The next one is co-infection with the herpes virus. We know that individuals living with HIV that have co-infection with the HSV virus, there is subclinical increase in shedding in these patients. Also, lymphatic fibrosis. So this is very similar to the microbial translocation and dysbiosis. So when somebody is first positive with HIV, you see an increase in activation of their lymphatic system. So you get lymphatic fibrosis. And then when they're under treatment, it doesn't recover in time. So that's how you get the chronic inflammation. And then lastly, we have inadequate immunoregulation. So what that means is that we know for a fact that a little bit of inflammation in our body, the response is good. But too much of chronic inflammation is not good. And so we have an arm in our immune system that actually balances that, so that it balances the chronic inflammation. But when you have persistence, there's going to be some kind of dysfunction, and that imbalance is causing the chronic inflammation. So there are a lot of ongoing, completed, and upcoming studies. A couple of them looked at low dose, so say for example the C's are the completed ones, low dose methotrexate or isoretinoin to decrease inflammation. These studies are being written up, the results. The preliminary results are not that promising, but it's something that we're looking at. The ongoing ones, 2 of them that really sit into my mind is the sitagliptin, Januvia, to reduce inflammation, and then the Reprieve study. So how many of you guys have heard of the Reprieve study? Anybody? Okay. So the Reprieve study is a multinational study. This is looking at the use of pitavastatin to prevent vascular event. So they're looking at individuals who are HIV positive. They calculate their ASCVD risk score, and if the ASCVD risk score is below 7.5%, they will either put them into a placebo group or they put them on pitavastatin, and to see if there's actually a reduction in inflammation. So I think we're at the last stages. How I know a lot about this study is because my colleague who's the head of this study at our site is always up my butt and trying to text me, did you ask this patient to see if they qualify? Well, I was like, yes, I did. And so that's why she's always on my case. That's how I know about it that much. So how does this change the way we manage patients living with HIV? That's the big question. We know for a fact that there is chronic inflammation. And this chronic inflammation, if our patients are living older, it's going to be unopposed. And they're going to develop non-AIDS defining malignancies, end-stage renal disease, cardiovascular disease. This is why we need to be prepared to be able to manage those chronic medical conditions as we see them. So this is a very fun question. If those of you at my talk this morning, apparently there was crickets because it seems like everybody was a little shy to put up their hands. I would like a little bit more participation. So what is the age of the oldest patient you have in your practice? Carl, I'm going to pick up 64? 64, that's pretty impressive. 81, I think she wins. I'm going to buy you a cup of coffee after, okay? Buy you coffee, okay, yeah. Carl? 60. So the oldest patient at our Pittsburgh AIDS Center for Treatment is 89. She's been positive for 35 years, has been on antiretrovirals. Her CD4 count is in the 400s, and her viral load is suppressed. But she has a lot of chronic medical problems, and that's where we're going to address today. So looking at the epidemic and looking at new models of HIV care, this is so important because, you know, in the Western countries, we've had this care model where in the 80s, there was the opportunistic infection era, which is basically a death sentence. When you were diagnosed with HIV at this point, you basically was just waiting to die. It was palliative care. A lot of the specialists were palliative care doctors. And it was really treatment of OIs. Have any of you guys seen the movie Dallas Buyers Club? Anybody? Yeah. Okay. That is actually one of my favorite movies. And when my parents asked me, who are here today, what do you do for a living? And I said, just watch the movie. And, you know, maybe you can have an idea of what I do. And so that movie really talks about the AZT era. The antiretroviral era was in the 90s. That was really focused on the HIV specialist, the focus on viral pathogenesis, and that was when triple therapy was applied. That was in the 90s. And that was, you know, back home in Canada, the Vancouver conference. But now we are in this chronic disease era, which is HIV disease management and primary care. So if you ask any of my residents or colleagues who practice HIV care back home, how many percent is actually HIV care? What do you think they will say? Carl says 30. It's actually closer to 20%. The other 80% is actually primary care. And so this is why this model is moving that way, because there are actually a lot of ID physicians in the US, in Canada, in the UK that don't practice HIV care because it's always changing and there's that huge aspect of primary care. So chronic HIV care, we know that HIV is a chronic disease. There is an increased life expectancy. If you look at the Athena trial, we know that for recently diagnosed and asymptomatic patients, that the life expectancy is relatively the same as someone without HIV. And the CDC in 2017 posted that 50% of patients living with HIV are actually over 50 years old. And the causes of death, if you look at the DAD study, the cohort, that the number one cause of death was non-AIDS defining malignancies. So it wasn't AIDS. It was non-AIDS defining malignancies. It was cancers. And then the second was cardiovascular disease, which is about 20%. So if you have a big proportion of your patients that are dying not from AIDS complications, but from chronic illnesses, we need to be a little bit more familiar with how to manage and prevent these illnesses. So I'm a little biased being a primary care provider. This is a self-reported level of comfort with prescribing treatment for, I saw that 15 minutes, I have 17, I'm just going by the time, okay? Comfort with prescribing of hyperlipidemia, diabetes, hypertension, and depression. And if you take a look at this, the dark bars are general medicine, which is internal medicine and family medicine, and the white bars is infectious disease specialists. And looking at the comfort of them managing hyperlipidemia, but look at the difference in depression. That is roughly about 80% to 35%. That is a huge difference. And so we know a lot of our patients that are living with HIV actually have a lot of mental health issues that we need to address. So why is it important to provide comprehensive primary care in patients living without HIV? So number one is we know that the life expectancy in these patients are similar to that of persons living without HIV, and they will inevitably develop all these chronic medical conditions. So think about your grandmother or your mother, the medical problems that they have, diabetes, hypertension. These are all things that patients will develop. And this is based on North American data, but more than 50% of patients living with HIV also have a psychiatric condition. So PTSD, schizophrenia, depression, anxiety. So it's that much more important for you to understand and learn how to manage these patients. So why is it important? Because it really does reduce barriers. We're minimizing off-site medical appointments. So when a patient comes to see me, they're able to get a lot of their chronic care, whether it's, you know, with their primary care, orthopedics, derm, their HIV care, all is under one place. And by doing this, it minimizes the number of referrals and where the patient's going. So if you think about it, it actually applies a little bit more here, right? A lot of your patients might come to your clinic, maybe it takes an hour or 2 hours by bus, by jeepney, by tricycle, and then they have to do that every time they go see a specialist. So by reducing that barrier to care, you may be able to help the patient not only with compliance with their medical appointments, but also with their antiretrovirals. We need to educate and to reduce the stigma that we have, and it's not just stigma here, it's stigma everywhere. And it's not only educating, our patients and their families, but healthcare providers and also the community. And then to provide culturally competent care and to advocate for necessary resources. So just to tell you a little bit about back home, the Pittsburgh AIDS Center for Treatment, the PAC clinic, was one of the first 10 HIV clinics in the country. It's a patient-centered model of HIV primary care with 1,700 patients. So in the clinic, there are 10 providers, 8 ID physicians, 1 family physician, that's me, and 1 physician assistant. But all of us, we do provide specialty HIV care and primary care. So all my ID colleagues that are doing this also do hypertension, diabetes, depression. We're there about 9 half-day sessions per week. We have consultative services in the hospital. And I can't stress enough the weekly multidisciplinary case conferences. At our clinic, we have no egos. Everybody treats each other the same. So we bring up difficult cases and we discuss them, whether it's a crazy genotype question, or it could be a patient comes 2.5 hours, how are we going to reduce these barriers? So these are all multidisciplinary case conferences. We have on-site subspecialty care, which is like anal dysplasia, gyne, musculoskeletal. I do all the joint injections at our clinic, addiction, and pain. And then we're also a major training site for ID fellows, primary care residents, and medical students. So one of the things is I'm also a director of the Family Medicine Primary Care HIV track. This is one of 9 tracks that graduate an HIV specialist out of the program, that they graduate from family medicine into becoming an HIV specialist. Now, I'm not trying to throw her on the spot today, but Ali Vogel is here with me today. Just wave, Ali. Thank you. She is my second-year family medicine resident that's in the HIV track. And after 2 years, she's going to graduate to be an HIV specialist. And so we have a lot of training there to move towards this primary care model. So some of the key concepts in the management of those living with chronic HIV, the biggest one we have to look at is cancer screenings, because that is the #1 cause of death in patients living with HIV. So the first one is colorectal cancer screening, right? These are guidelines for those without HIV, and that was starting at the age of 50 and then continuing to the age of 75. We either recommend a sigmoidoscopy, a colonoscopy, or a FIT test. Now, for those of you who don't know what a FIT test is, that's a fecal immunochemistry test. So you basically have a bowel movement, you take a little sample, you put it on a card, and you send it in. And if the lab detects that there is any blood, then they recommend a colonoscopy. If it's negative, then you repeat it next year. And these same guidelines apply to patients living with HIV. Breast cancer screening, so we go by the American College of Obstetrics and Gynecology. These are the same recommendations in the UK, Canada, and Australia. So women at the age of 40 are offered screening mammograms. And if they choose not to, though, they should have their first mammogram no later than 50. But this is a shared decision-making that they're having. And this also applies with patients living with HIV. Our cervical cancer screening, so we know cervical dysplasia is higher in patients living with HIV. So with women ages less than 30, they will have 1 pap smear following initial diagnosis, and it should be repeated every 12 months. After the first 3 are negative, then it can be spaced out every 3 years. But they don't recommend pap testing with HPV because there was no evidence that it was going to change any of our outcomes. Now, if somebody is younger than 21, then 1 year after initiation of sexual activity, then they should have a pap smear, and this is a grade B evidence. And then women who are age 30 or over, they recommend pap testing with HPV, co-testing at baseline, and if it's negative, go ahead and repeat every 3 years. One of the last ones I want to talk about is anal dysplasia. So we know that anal dysplasia is very, very prevalent in our MSM population. So MSM, any patient with a history of anal genital condylomas, and women with abnormal cervical and or vulvar histology. So they recommend anal cytology at baseline and annually in the stated populations with HIV. So the only other one I didn't put up there was actually lung cancer screening. We actually see a lot of cases of lung cancer, but the screening guidelines that we have actually doesn't have a lot of evidence. They recommend that they do a low-dose CT scan between the ages of 55 to 80, but the number needed to treat is actually a very poor number. But smoking cessation counseling is very important and probably a good idea to do during your office visits. Cardiovascular health is the second one. And that's really important because of the fact that we know that our patients are affected when it comes to cardiovascular health. So we use the ATP4 guidelines. I know some of you know that about 2.5 weeks ago, the ATP5 guidelines just came out. Now, the American Academy of HIV Medicine hasn't adopted these guidelines yet, so I'm going to stick with the old ones. So making sure that if the patient has a history of heart disease, peripheral vascular disease, and stroke, to go ahead and start on a high-intensity statin. If their LDL is greater than 190 milligrams per deciliter, then a high-intensity statin as well. If your patients have diabetes and they're between 40 to 75 and have an LDL between 70 to 189, they should be started on a moderate intensity statin. And then lastly, if their ASCVD risk score is above 7.5%, then they recommend that to start a statin. And any combination of 3 and 4 should be on a high intensity. So primary prevention data is not that great. But we know that no cardiovascular calculators include HIV. And we know HIV is a chronic inflammatory disease. So we're a little bit more liberal when it comes to starting a patient on a statin. Chronic ART effects. So we talked a little bit about this morning. I'm not going to go too in depth with this. A couple of the medications like abacavir, be careful of the hypersensitivity and the cardiovascular events. This is more in European models and also animal models. Zidovudine, make sure you're checking your CBC. A lot of anemia. You get also avascular necrosis and peripheral neuropathy. TDF, tenofovir disoproxil. Kidney function, checking your BMP and urine analysis every 6 months. And bone health, which is checking a DEXA scan at the age of 50 and over. Nevirapine, hepatotoxicity and rash. Efavirenz, dyslipidemia, CNS effects, and mental health. Please don't forget that our patients do have issues with mental health, so you can do something as simple as a PHQ-2. There's just basically 2 questions to assess at a baseline if your patient has any type of depression. And lastly, with lopinavir, ritonavir, we should probably remember to check their lipids and to look at cardiovascular health because it does prolong a lot of QTc and there's a higher risk for metabolic syndrome. The drug-drug interactions, as we talked about this morning with rifampin, are pretty big issues that we have here, and that's something that should be addressed. And hopefully with dolutegravir, approved by the WHO, I'm going to keep my fingers crossed that the Philippines will have that medication soon. Lastly, don't forget vaccinations. We want to keep our patients out of the hospital. That's the purpose of vaccines. I know that in the Philippines there has been a lot of issues with vaccines, especially with the dengue vaccine. I'm not here to debate that at all. That's for a whole other session that does not involve me, okay? But your pneumonia vaccines, so your Prevnar and your Pneumovax, your meningitis vaccines, so your Menveo or your Menatra, tetanus, shingles. You guys know that there's a new shingles vaccine, the Shingrix. It's 12 times better than the Zostavax, that it was a live vaccine. And the age difference is shingles, you can give it at the age of 50 and over versus 60 from the live vaccine. Hepatitis A and B, HPV, you remember now that patients can be older than 26 to have the vaccine. 45, thank you, Carl. And influenza, I know we have different strains of influenza, so definitely get your flu shots. So lastly, I love this quote, because who is an HIV specialist? HIV disease does not fall under any one medical specialty. Physicians trained in internal medicine, family medicine, and other medical subspecialties join infectious disease specialists and HIV experts. And this was published by the IDSA. So before I finish, excuse me, I do want to thank a couple people. Bernard Makatengai is one of my colleagues back home, and Deb McMahon, who runs our clinic, who's always been supportive of my career. Dr. Alejandria, I want to thank you for the invitation and always for supporting me while I spend my time here over the last couple years. Dr. Silvana for teaching our residents and really having that educational background for backup. My good friend Carl Henson was my first Filipino medical friend when I was here in the Philippines, and I really do appreciate your friendship. And Rose, if she's here, I don't know how you do it. You put up with so much with me for me coming here, so I wanted to say thank you. And lastly, my family, my parents, and my wife who came all the way from back home to come support me. I really appreciate it. Thank you.
Dr. Liu, may I request you to remain on the stage for the awarding of the Certificate of Appreciation? May I call on Dr. Alejandria, is she here, to join us?
This will be familiar to you now. The citation, or the Certificate of Appreciation reads, we give this Certificate of Appreciation to Dr. Gordon Liu for sharing his invaluable insights and inspiring words of wisdom as plenary speaker on the topic long-term consequences of HIV infection and chronic ART, thereby contributing to the continuing medical education of the society on the occasion of the 40th PSMID Annual Convention. Signed, Dr. Rosario, the Chair of the Scientific Committee, Dr. Alejandria, the Vice President and overall Chair of the Convention, and Dr. Panaligan, PSMID President.